morning, everyone. It's Melissa Andrews with LeadingAge Virginia. Thank you for being here for our weekly Wednesday member coronavirus update. We have a jam-packed agenda for this morning, starting out with Christy Gray from the Department of Health. And we're so delighted, Christy, that you made the time to join us this morning. Are you on?
Good morning. Yes, I am.
Great, Christy. Thanks so much. And I'll hand it over to you.
Great. Good morning. Thank you so much for having me. I'm very excited to be here. I'm sorry, I'm kind of waiting for the screen to pop up here. I'm having issues connecting to the video. So I'm just going to pull up my presentation on my computer really quick. So I am here. I'm the director of the Division of Immunization here at the Virginia Department of Health. And I believe the first slide you should be seeing is influenza. Can somebody clarify that?
Yes, that's what we see, influenza vaccine planning.
Perfect. Okay, great. So the one thing that I really want to drive home about influenza, we've been talking for several months actually about how important this flu season is going to be compared to any prior one. And that really is to try to help ease the stress in the healthcare system when we're going to have two respiratory illnesses circulating. We have a vaccine now against one of them, and so we can help prevent the transmission of flu now, and that's something that we can take action on now. So I really want to encourage every facility to make a plan. How are your residents and staff going to get vaccinated? This season, of course, is also different because of COVID. Many ways in which people are used to getting vaccinated, especially your staff, aren't as readily available or aren't as part of routine as much as they used to be. Perhaps you used to drop off at a pharmacy on the way home and get a quick, or in some instances, people are used to vaccinators coming into their workplace, and perhaps that might not be possible this time. So it's we have to practice social distancing, so you can only vaccinate so many in a given time frame when you could have had the physical space to fit more people in. So there's lots of things to be considering this year, and be making that plan. How are you going to get your residents vaccinated? How are you going to ensure that your staff can get vaccinated? Internally, are you bringing people in? Are you giving vouchers? Are you sending people out? Definitely be thinking about that plan, because it's going to be different this year, and it's easier to plan for these things rather than reacting and realizing, oh, that did not work. And it's I know you have a lot. I see the other things you guys are talking about today. You have a lot on your plate. This is something that you can check off, get it done, instead of having it built up and then becoming more urgent the longer you wait. The flu vaccine should be arriving in different facilities, if not already, within the first or second week of September. We're encouraging people to try to get vaccinated as soon as possible, because so many people have to get vaccinated. The sooner we can get it done, the more people we can fit in before the flu viruses really start circulating. Just a reminder, you need 2 weeks of time between getting vaccinated and when you're exposed to the virus for your body to be able to have built up the protection it needs to fight off the virus. If you're exposed before that 2 weeks is completed, you will not have had enough time to protect yourself, and you would get ill. So that's why we always encourage people, allow that time to be able to build up the protection. We, healthcare workers aim for 90% vaccination coverage for flu. And one of the things that, again, is different this year is that you're going to have both SARS-CoV-2 virus and flu viruses circulating. I see the flu vaccine as taking flu off the table. When you have somebody who is symptomatic, and many of the symptoms are similar between COVID and flu, so take flu off the table. That wouldn't be a consideration if you get vaccinated, and you have lesser amount of people becoming ill as a result as well. So another thing that I want to really hit on today is the Virginia Immunization Information System. We have had several facilities start to reach out to us about enrolling and onboarding with this because there are benefits beyond COVID-19 vaccine requirement. But there are several benefits to a facility to become enrolled, and you want to do this now rather than in the future when it will be much more hectic in needing to do it when you want the vaccine and can't get the vaccine because you've not taken these steps yet. Next slide. So speaking of the Virginia Immunization Information System, so just in case any of you aren't aware, this is a system that consolidates immunization data from multiple sources into one definitive and accurate record. And having this type of system allows healthcare providers to make better decisions about which vaccine a person is due for. And this can increase immunization rates and decrease over immunization. Providers requesting somebody be vaccinated for a vaccine they are not due for. And so this system can help in both of those respects. There's no cost in accessing this through its website. The training is free, access is free. You do need to have internet, but otherwise it is free to access the system and use it. It is user role specific, so you get access only to the information needed to do your job. You can also, if you have electronic health record system, you can connect it to this. There may be fees associated from your electronic health record system, but not from this. And so that's something to have a discussion with your EHR system about, and there may be potential CMS funding that could help cover that cost. We have also heard from many offices how they successfully integrated this into the current business flow without disruption. We have testimonials of providers saying, I don't know how we did healthcare without it. It's fantastic. Once you learn how to incorporate into the system, it can be very helpful to your provider and especially to your residents. This PowerPoint presentation has a link to a 10-15 minute training video at the bottom of this slide that you can link to and look at to see how to navigate within the system. And then here's the email information at the bottom. Please reach out and get enrolled with this now, because there are lots of people who are going to be interested. And so the sooner you can get this done and checked off, the sooner you will be ready if you want COVID-19 vaccine to administer to your residents or staff. Next slide. And I just wanted to update you on the COVID-19 vaccine situation. We are still several months out from having vaccine available, but the landscape continues to be very complex and it's constantly evolving. So we do have weekly calls with the CDC on different updates on the systems and the policies and the research and the trials and everything that is happening with the vaccine. We do anticipate there will be at least 2 phases, with the initial phase having limited supply and that it would be provided in closed capacity events to specific priority groups. Those priority groups are still being discussed, and at the federal level, as well at the state and community-based levels, and including different stakeholders to understand what the federal recommendations would be, but then what is best for Virginia and Virginia residents, and how we are handling COVID and what our response should be. The vaccine remains very complex. There will be up to 7 different types by the second phase of the COVID-19 vaccine response. The second phase is likely to start 3 to 4 months after the first phase, and the second phase would be where there's more supply of vaccine and therefore available at more traditional vaccinator providers, pharmacies, hospitals, for people to get vaccinated. The types of vaccines are still being under clinical trials. How many doses will be required, 1 or 2 doses in a series to complete the series. The storage and handling of the different vaccines will be different. The administration would be different, and if you have a 2-dose series requirement of a vaccine, they are not interchangeable with each other. So if you start a series with one of the vaccines, you have to finish it with that vaccine. We do expect that there's going to be varying efficacy and adverse event profiles in different populations. What might work well in a senior may not work well with a young adult or a child. The distribution is still being, details are still being finalized of how the vaccine will get distributed. The priority groups, as I mentioned, are still being discussed. Likely first priority groups may be healthcare workers, first responders, essential workforce, and high-risk populations. The reporting of doses administered, I mentioned this before. All doses of COVID vaccine need to be accounted for and reported to the CDC. And so Virginia will be using this in order to account for every dose that's administered. So if there's going to be a vaccine that's being administered at your facility by your staff, you need to be enrolled and provide it into this. The communication and education around this vaccine will be complex as well. We need to make sure that we're being culturally appropriate in messaging. What might make sense for one population might mean very different things to a different population. So understanding that and ensuring that we're being transparent in everything of this response, especially for those that may distrust public health. And so the landscape is very complex. We are getting updated weekly and updating our own vaccination plan and response as a result, and trying to also update all of our stakeholders, including yourself, in this. So the take home for your facilities is to, again, consider the plan of how your facility staff and residents will be vaccinated. Are you going to do it internally? Are you going to bring in a contractor? Are you going to send staff out or expect residents to go out externally to get that vaccine? Think that through, and please reach out to us if you have questions of what that, based off of your plan, what that would mean and how you would expect that, or if you need help talking through your plan, please reach out to us. We want to make sure that we have an open dialogue between our team and your facilities, and of course LeadingAge, to ensure the communication is open and that you have all the information you need to make the plans and decisions that you need to make. We are also going to be rolling out a provider COVID-19 vaccine registration or intent form. This is a form that we want any provider in Virginia interested in administering COVID-19 vaccine to their patients to complete. And this is the name of the facility, this is the prescriber, the shipping information, the type of facility, what type of refrigeration or freezer space do you have for storage, and what type of population do you have? Do you have high risk healthcare worker, other types of priority groups that we might want to identify how we can reach. And this form is being in development, likely to be rolling out in about 3 weeks. And this would be your way to indicate to VDH you're interested in getting vaccine, so we can get you set up and make sure that you have all of the requirements of the systems that you would be enrolled in completed before vaccine comes off the shelf, theoretically. And then I'm also going to put in, again, at the bottom of the slide, this plug about contacting us to get set up with this as soon as possible. That is all I have today.
Well, that was a lot, Christy. Thank you so much for this comprehensive overview. Right now, there aren't any questions in the chat box. Just a reminder, if you do have a question for one of our speakers, please enter it there. And I think, Shayna, are you on the line?
I am on the line. Can you hear me?
Yes, great. Thank you so much, Shayna, for being here once again. I'll turn it over to you.
Yes, thank you for having me again. So this week I'm going to be discussing the recently released CDC Interim Guidance for rapid antigen testing for SARS-CoV-2. You can go to the next slide. So before I go over the sort of details, I just wanted to do a little bit of background on some of the terminology that's included in the CDC's document, just so that we're on the same page whenever we're discussing this and whenever you're looking at my slides. This is just sort of a reference whenever I refer to either a diagnostic test, a screening test, or a surveillance test. So diagnostic testing is going to be referring to persons who have signs or symptoms, or a person who is asymptomatic but has recent known exposure. So both of those categories will fall under diagnostic testing. The other type of testing that's relevant to the long-term care population is screening testing. And so the purpose with screening is to identify persons who may be contagious so that measures can be taken to prevent further transmission. And so this is specific for testing in congregate settings, such as long-term care facilities or a correctional facility, a workplace testing its employees, or a school testing its students, faculty, and staff. And then the last type of test that you would do is a surveillance test. However, this is really to monitor for community or population level infection and to characterize incidence and prevalence. So this isn't really applicable to our discussion, but I wanted to include it for completeness. So for today's discussion, we're really going to focus more on the diagnostic and screening testing. You can go to the next slide. So I encourage everyone to kind of take a look at the CDC's updated antigen guidance that was released. And so what I tried to do was answer two questions. The first one being, based on the CDC guidance, when can antigen testing be performed? Because I know this has been a little bit of a hot topic. So, you know, just sort of addressing the elephant in the room that currently the CDC, whenever it was released, had 2 rapid antigen tests. There's actually now a third that have received EUAs from FDA and are limited to diagnostic testing on symptomatic persons within the first 5 days of symptom onset. So that's, you know, per the FDA, and that's sort of box number 1, that antigen testing can be performed, diagnostic testing on symptomatic persons within the first days of symptom onset. Where it then gets a little bit more muddy, and I will say I think one of the criticisms of this document at this time can be that I don't know if it necessarily clearly answers this question, but they do include information regarding screening and then testing close contacts. So I'm going to sort of present just a high-level summary of what they say. So the second box in the middle is referring to serial screening testing and high-risk congregate settings. So the CDC does include the modeling evidence that shows that outbreak control depends largely on the frequency of testing, and the speed of reporting is only marginally improved by high test sensitivity. So that's based on this modeling evidence that I've linked to the primary literature, showing that different testing frequencies and different sensitivity based on a model, which is essentially what they're trying to say is that using an antigen test, which we know has a lower sensitivity, but if you're frequently doing it, you can sort of overcome that lower sensitivity issue and could maybe beneficial in a congregate setting, such as a long-term care facility, to be able to rapidly identify those that are positive so that we can take control measures to stop the spread, which is our goal. So they do talk about using antigen tests as serial screening. And then the last which sort of group is testing close contacts. They don't really say much about it, but they say it may be informative in diagnostic testing situations in which the person has a known exposure to a confirmed case of COVID-19. So they mention these three, but then sort of a couple paragraphs later, they do say there are limited data to guide the use of rapid antigen tests as screening tests on asymptomatic persons to detect or exclude COVID-19 or to determine whether a previously confirmed case is still infectious. Now, screening tests, this is sort of right after they talk about serial screening testing in these high-risk congregate settings. So whether they're referring to screening tests outside of high-risk congregate settings is sort of up to whoever is reading interpretation. So I just kind of wanted to point out the three areas where they say it, and then some other just pertinent information snippets from the guidance document. You can go to the next slide. I know I said this last week, and the CDC probably says this about 3 times in their document, what's in the blue box. So I would be remiss if I didn't say it again, that when you're evaluating the results of any test, including a rapid antigen test, you should take into account the performance characteristics, so really understanding the sensitivity and specificity, instructions for use of the FDA authorized assay, the prevalence of COVID-19 in the area. So you can look at the positivity rate over the previous 7 to 10 days or cases per population, and the clinical and epidemiological context of the person who has been tested. And so they discuss that you really need to think through what the positive and negative predictive values of all in vitro diagnostic tests, because they vary depending on the pre-test probability. And whenever we talk about pre-test probability, this is impacted by the prevalence of the target infection in the community, as well as the clinical context of the recipient of the test. So the pretest probability sort of boils down to, before you take this test, what is the likelihood that this test is going to be positive or negative? If it's a high likelihood, then it's a high pretest probability. The CDC recommends that laboratory and testing professionals who perform rapid antigen testing should determine infection prevalence based on a rolling average of the positivity rate of their own SARS-CoV-2 testing over the previous 7 to 10 days. So you can go to the next slide. And so this is just the second question that I tried to answer, because this is also something that's been debated about antigen testing is when is confirmatory testing recommended? It talks about it in the FDA EUA. We understand that the sensitivity potentially can be lower. However, that pretest probability will dictate whether or not you should consider doing a repeat confirmatory molecular test. And so I try to go through the guidance and just create a 2x2 table based on what they were saying. So we have either a diagnostic test or a screening test, and then whether it's antigen positive or antigen negative. So that first row, the diagnostic test, you will need to consider the length of time the patient has experienced symptoms. Again, we know that there's this window for antigen tests being positive the EUA says, sort of 5 days. However, I'm sure that varies patient to patient, but we do know that the antigen viral level decreases as symptom onset increases. So if you're antigen positive and it was a diagnostic test, so meaning that either the person was symptomatic or they were a close contact, you're probably going to have a high pretest probability that they are positive. So if someone in this scenario tests positive with an antigen, they may not necessarily need to have a confirmatory test. Generally, clinicians can rely upon test results because the specificity of the current FDA authorized antigen tests are high. Now, if that same person tests negative, because you probably had a high pretest probability, confirm with either RT-PCR or molecular test, ideally within 2 days of the initial antigen test. But if that sort of testing is not available, clinical discretion should be used whether to recommend that the patient isolate or not. So again, going back to that previous slide of thinking through why you're doing the test. So is this a diagnostic test? Is the person symptomatic? What is the prevalence in the community? Do I really think that this person has COVID-19? And then interpreting that test result based on, knowing what you know about the antigen specificity. And then the last row is for screening tests. And so if you're screening someone, again, whenever the CDC is talking about screening, they do include the modeling evidence for congregate settings. So potentially if you were doing screening of long-term care staff, potentially you're doing this every week. Then if it's a positive test and you had a low pretest probability, so maybe the community positivity rate isn't that high and you're doing this screening test, you might think, well, that positive test result might not be accurate. So you would still isolate them, but you would want to confirm that positive test with a more sensitive test to make sure that they are actually positive for COVID. If you have an antigen negative test and there's that low pretest probability, it may not be necessary to sort of repeat any sort of confirmatory testing. And then they also specifically call out that if you're part of a cohort that will receive rapid antigen tests on a recurring basis, that a confirmatory test may not be necessary as well. So I think we're still having ongoing discussions about this, but I did think it was helpful that the CDC's guidance did try to address some of these outstanding questions. Next slide. And so sort of these are our next steps. Guidance. So we are awaiting additional CDC guidance. We were told that there would be CDC guidance for nursing homes, specifically for antigen testing, or potentially just an update to their nursing home testing page. I haven't seen that yet. That was over a week ago that the CDC said that, and they said it would be coming soon. So I'm not exactly sure what the delay is. And then the other piece of this is the CMS updates, which it sounds like you're all going to have a discussion about this in a second. So we did have some published last night. However, we're still awaiting additional guidance with more specifics on that. But we want to take what the impending CMS requirements are, thinking through these antigen tests, to be able to then update our current VDH testing guidance. We also are going to get input from stakeholders. So yesterday, a little bit difficult whenever it's still theoretical or sort of not necessarily in writing what the CMS requirements are going to be, but we're sort of doing our best job to kind of start these conversations to kind of determine what changes need to be made to our testing recommendations and what are going to be requirements from CMS that we're just going to have to address and think through whether an antigen or molecular test should be used, and then based on that result, whether or not you should follow it up with any sort of additional test. So we are going to be seeking input from a lot of stakeholders. And then based on the input and based on some additional guidance, we will be revising our VDH guidance. So right now we have posted, which I talked about last week, our VDH antigen testing guidance. That again was just our first best guess. There was an absence of any sort of guidance. So it's great that the CDC has come out with some guidance now. We would like it to be a little bit more specific to nursing homes. However, we will be taking, what they've said in conjunction with what we have said with antigen testing, and then also see what CMS is going to say to make one testing package to make it a little bit more straightforward whenever you're going through this, or at least that's the goal, is to kind of make some of these things more straightforward as we have more information and learn more. We kind of want to combine all of the testing guidance so that we have one document. So we will be working and have been working on updating this based on the new guidance. And I think that's all I have.
Well, that's a lot, Shayna. So I don't think it's that's all at all. I think it's a lot. So thank you so much for being here and for your honesty about it being muddy and that we're all trying to wade through the mud together. So we'll wait for more guidance to come out. And, speaking of muddying the waters, Jody, are you on to talk about what came out from CMS last? Oh, wait. Shayna, we have a question that came in for you real quick. Should routine surveillance testing be conducting in a nursing facility or AL setting? If so, what confirmatory testing is recommended?
And just to clarify, when you say the term surveillance, you're referring to my first slide where surveillance testing is really for, kind of part of a research or sort of part of a public health initiative, and they don't necessarily address that. And the surveillance testing, the results are not reported to the individual patients. It's more at an aggregate level. So I would say most likely those wouldn't be repeated because it's not for patient management, and that's the reason why you would do sort of this confirmatory testing is for patient management. So if you're talking about surveillance testing as per the definition and that first slide, again, those results are not intended to be reported back at the patient level. That's aggregate data just to be able to determine prevalence. So those wouldn't be necessarily followed up with any sort of confirmatory testing.
Great. The person who asked the question said thanks for the clarification. So I think you answered it spot on. And if any more questions come in, I will let you know. But transitioning to the federal level, Jody, did you get any sleep last night?
A little bit. I got a little bit of sleep. Yeah, it's been a really busy week and a half probably. I have so much stuff to tell you guys, and then CMS came out with all this stuff yesterday that just really changed everything. But I'm glad Shayna covered the antigen testing stuff, which was really important. And I will add to that FDA released an FAQ on Monday that is very consistent with what CMS or CDC is reporting about the antigen tests. But I say that because a lot of people have had questions and they keep going back to the FDA guidance that you shouldn't use antigen tests on asymptomatic individuals and blah, blah. And so this FAQ really clarifies it the way that Shayna just explained it. So we're glad to see that now everybody's kind of getting on the same page. I think they were on the same page to begin with, but now they're just very clear with all of us that they're all on the same page. So that's good. So yeah, CMS put out a rule. They released it yesterday. It's an interim final rule with a comment period. It's got a 60-day comment period, so LeadingAge will be submitting comments, but it is not yet available on the Federal Register. And the reason that is important is because these many pieces with these rules are effective on the date of publishing. So since it's not been published yet, it's not technically effective, but it's imminent. So a lot of the pieces of the rule will sound familiar. They are putting into the rule what was previously in guidance, and they have added some enforcement capabilities, but a lot of it will also sound kind of vague because they will be relying on guidance that is forthcoming to spell out some of the new parts. So I'm going to start with the small pieces so that they don't get overshadowed by like the big fat testing piece. So some of the smaller pieces, your SNF VBP is now going to be based on a full 12-month calculation that omits part of the public health emergency. This is something that LeadingAge had advocated for over the past several months with the SNF PPS rule, because CMS had kind of suggested this other way of calculating the BBP, and we said, hey, we appreciate that you're taking out the public health emergency piece, but that's still not going to give us the full calendar, or I'm sorry, the full 12 months that it would be compared to previously, and that's not really going to give us a great picture. So we were glad to see that they did incorporate that into this rule that they released yesterday. Another piece of this rule is changing orders for testing. So you'll now need an order for COVID-19 testing after your initial test. Previously, you did not need it for your test, but now you can have one initial test without an order, and then after that, you'll need to have your subsequent orders. But I think for nursing homes, that's probably not as much of a concern as it would be for folks living in the community. They've also expanded the authority for who can order those tests, so it now includes pharmacists and other practitioners who are able to order tests under the scope of practice. They talk about the enforcements for failure to report COVID-19 data through NHSN. Now we know about this, right? We've already seen this, but now it's actually in regulation instead of just being in the sub-regulatory guidance. The regulation for reporting came out in May, but the CMP part of it was not spelled out. So now that's in there. And on a side note related to NHSN, they are scheduled to update the data elements again tomorrow. So they're going to now be collecting data on point of care testing. They are working to update the CSV templates and to notify anybody, any groups who are doing the group reporting and the CSV, all of that. I haven't seen it updated on the site yet. I keep checking, but those updates are scheduled to take place tomorrow. They're also encouraging users to update enrollment at some point over the next 2 months. Now, remember, when we went through this whole thing to begin with, a lot of folks opted to do the expedited enrollment process. It brought you in on like a level 1 where you were able to access the system, but you didn't have that full security, the SAMS grid card and that sort of thing. That enrollment process takes a couple of weeks. CDC is hoping to transition everyone over in the next 2 months. They're working with a pilot program right now of about 250 nursing homes, and they will reach out to all of us to let us know. So sit tight for now. You don't need to proactively go out and try and upgrade your enrollment yet. CDC will put out very clear information. NHSN will put out very clear information to all of us, but I wanted to let you know that when you do receive that information, it's not spam. They really are trying to get everybody upgraded. And the reason is because currently when you report through NHSN, you're reporting on facility level data. This new upgrade will allow you to report on patient level data. One of the things that they're putting out there is the ability to report test results. So we have been advocating, and it is our hope this is the direction it's headed, that you would have a streamlined reporting process. So those reporting requirements for the point of care testing that you have to be reporting, our hope is that you would be able to report it through NHSN and not have to do the separate reporting. We'll see how all that plays out, but that's just a quick heads up on that. So back to the rule, they've also included enforcement for the failure to report according to those HHS lab data reporting. Remember, that was the June 4 guidance that we all have to comply with. I don't think that's new to anybody. You guys are aware that if you are using one of those point of care testing devices, you are required to report on every test, and it needs to be reported within 24 hours. The actual guidance says you need to report to the secretary, and then the secretary came out and said you're going to be reporting to your state and local health departments for that. This rule includes the enforcement though. If you do not report, it's $1,000 for the first day that you don't report, and then $500 each day after that, up to $10,000. Now, remember that that's different from the enforcements for not reporting through NHSN. With NHSN, it's $1,000 for every week that you're not reporting, plus incremental increases of $500 on top of that. So $1,000 the first week, $1,500 the second week, $2,000 the third week, all the way up to $6,500. But with this reporting for the lab data, it's $1,000 the first day and then $500 each additional day. And so now the big piece, the piece we've all been waiting for, requirements to test staff and offer testing to residents. Again, somewhat familiar, somewhat vague. CMS and CDC had both issued recommendations that nursing homes should be testing all residents in response to an outbreak and testing staff regularly and also in response to an outbreak. Now this puts it into regulation, but this is the vague part, those parameters about when you need to be testing or offering testing to residents, since residents do have the right to refuse, those parameters will be defined through a forthcoming CMS memo. CMS says it should be out this week. It hasn't dropped yet, but we will keep an eye out for it. Some of the suggestions that they make for the parameters would be anytime there's a new diagnosis, anytime anyone shows any symptoms consistent with COVID-19, specific parameters about county prevalence, and they didn't include in the rule what that county prevalence would look like, but what we've heard is that for counties that have less than a 5% positivity rate, meaning less than 5% of the tests that are conducted return positive, you would test one time a month. For counties that are 5 to 10%, it would be one time a week. And for counties that are greater than 10%, you would be testing 2 times a week. They also mention an option about testing response time, but we still don't know what that looks like until the CMS memo comes out. They do say in the rule, of course, as we are aware, that staff includes those who are actually employed by the facility, as well as those who are contracted to provide services like your hospice providers and any volunteers at the facility. They say you do have flexibility to choose the type of testing as long as it's within the parameters set by the secretary. So that would mean, turnaround times. It also has to meet professional standards of testing. There's 2 pieces of concern, though, around all this testing that I want to make sure everyone's aware of. The first is surveyor testing. We have heard a lot about this throughout the pandemic, but especially over the last couple of weeks. It's something that we have been talking with CMS about since the very beginning. And for a very long time, CMS was saying we are not requiring testing of surveyors, partly because surveyors operate in a different way. They are not generally providing direct care to residents, and they are not generally in as close contact for a prolonged period of time with residents the way that staff members would be. So that was kind of the reason that they were not requiring the testing of surveyors, as well as the fact that surveyors, are wearing PPE. They are required to be properly donning and doffing the PPE. But we do know that in recent weeks, CMS has been talking with states, and we know that some states have actually put into effect that surveyors would be required to be testing. The important part that is actually included in this rule is that you cannot deny entry to a surveyor. So even if they are not testing surveyors, if the surveyor has been screened, they don't have symptoms, they don't have fever, they do have proper PPE, if you deny entry to a surveyor, you are violating your statutory obligations. We have heard in some states that that puts you on track for termination of your provider agreement. So I wanted to make sure everybody's aware of that. The other thing in this rule that kind of made me a little bit nervous last night was that they were talking about how any staff member who is showing, or residents, anyone who's showing symptoms consistent with COVID-19, you have to take immediate action. So that could be cohorting, that could be excluding from work. So that means if staff are showing symptoms consistent with COVID-19, they must be excluded from work. A lot of times we hear questions about, this person has a headache and they have a cough and they have a runny nose, but it's just allergies. Well, I don't know. How are you going to prove that it's just allergies if you don't have a test or some other way to determine that? And now here it is right here in regulation that you could be in big trouble if you're not excluding those people from work. And then it also says the secretary will determine the criteria for return to work. And the reason that concerns me is because remember a few weeks ago, CDC kind of walked back their recommendations about return to work. They had previously said that test-based strategies were an option. And then after some further research came out, CDC said, you know what, we're finding that actually a symptom-based strategy is the way to go because some people are testing positive long after the time period has passed where they can actually spread the virus. So it's keeping people in isolation longer than they need to be. It's excluding people from work longer than they need to be excluded. And so with this little statement here about the secretary determining criteria for return to work, it makes me wonder if the secretary is going to determine that we do need to be a test-based strategy. So we're awaiting that CMS guidance to know how that plays out. But those were just a few things that I wanted to make sure everyone was aware of. And that is, that's the nuts and bolts of that rule. And we'll have more information once the guidance comes out and we see how it all shakes out.
Jody, I can't thank you enough for your diligence, and to the whole policy team at National. I know that when this stuff comes out late in the day, you all are burning the midnight oil so that you can help us understand it. So we really appreciate that so much. There haven't been any questions come in the chat box yet, but I want everybody to stay on the line. I know you're used to hearing Dana's voice on these calls, and you're about to again. Dana was watching some of our members testify at the General Assembly this morning, and she's got good news. So Dana Parson, the microphone is yours.
Oh, thank you, Melissa. I'm really, really excited to share this news with you all. In current law, our nursing homes have liability protections in place for providing care. In cases of gross negligence, that would be an exception. So with COVID, we've been working behind the scenes with the Trial Lawyers Association and a number of stakeholders to work to try to have hospice, home care, assisted living, and adult day added to these liability protections. It was touch and go there for a while. It was narrowed down to assisted living, but then we were successful in getting home care, and adult day added back in. So there's been a lot of work behind the scenes. The General Assembly is meeting virtually. If you haven't had a chance to check that out, it's very interesting. So this bill was being heard in the Senate Judiciary Committee this morning. We've heard a lot of opposition from it, from stakeholders, I think, who don't understand the bill and see it as a free pass for providing poor care in nursing homes, and that's not what this is about. This legislation is about making sure that following COVID, we don't have lawyers swarming around your communities looking for lawsuits. So that's what we did. The bill was heard this morning, and I just want to give a huge shout out to Carla Groff and Allison Zuba, the co-chairs of our Adult Day Council, and Charles Down, counsel with Brandon Oaks, for testifying this morning on the bill. And then also Westminster, Canterbury, Richmond, Lake Prince, Kings Grant, Sunnyside, Goodwin House, Covenant Woods, and Petersburg Home for Ladies for their advocacy this week for reaching out to all the members that serve on the committee. So I'm very pleased to report that the bill just passed the Senate committee unanimously.
Woohoo!
Yeah, so that's really great news for our members. Now it has to go to the floor vote, which shouldn't be a problem, and then over to the House side. So I'm very pleased that we did not have any major opposition to the bill, and we'll keep you posted.
Well, we want to thank our Public Policy Committee that helps us shape all of our legislative efforts. And I see a comment from Tracy Jennings. Great work, Dana and team. I'm sure Carla Groff did a nice job today presenting and representing members. Thank you to all who advocate for us. So something positive in the midst of all that is going on around us. I don't see any other questions in the chat box. I want to thank Christy and Shayna and Jody for joining us once again, for the depth of everything that you shared. And to our members, we are here for you. So if there's anything that you need, please just let us know. Thank you for your membership, and I hope you all have a great rest of your week. Bye, everybody.